On behalf of the Workforce Development Regional Partners, the Tri-County Council, and the College of Southern Maryland, I am really pleased to welcome you to this healthcare industry town hall meeting. I'm really especially honored to be with some of the heroes and heroines of this pandemic. I know you all are very busy, and so really thank you for being here and for sharing your time today. As you know, the partners have brought us together to discuss the impact of the pandemic on Southern Maryland's healthcare workforce. Very importantly, we want to spend this time conversing about your needs, your pain points, and your successes in order to begin developing coordinated workforce recovery strategies together. So before we begin, I want to go over some housekeeping. First, a note that this meeting is being recorded. That is for note-taking purposes only, but do be advised of that. Second, if you haven't already, please mute your microphones to minimize background noise distractions. And by all means, feel free to post comments, questions, thoughts in the chat area at any time during this discussion. Please be sure to select everyone as the recipient because we do have a number of chat monitors keeping an eye out for your comments, and they will read your comments aloud to all of us. Now, with respect to our format today, I'm going to begin with a general overview of the white paper, Getting Southern Back to Work, Getting Southern Maryland Back to Work, the initiative that this town hall is part of, and again, that you received some instruction about via the white paper. Then I'll be joined by Elaine Hardy of the Charlotte Hall Veterans Home and Dean Teague of Calvert Health for an opening dialogue about Southern Maryland's healthcare workforce recovery. We'll hear their perspectives on your industry's specific needs, challenges, and prospects. But again, please feel free during that conversation to post your responses and questions because then we'll open the floor after that opening dialogue so that you can weigh in. So we want this to be sort of a free-flowing conversation. Just again, feel free to add your comments, thoughts, questions at any point during our discussion. We will devote most of our time to the closing opening discussion. That sounded like an oxymoron, but the open floor discussion is how we'll spend most of our time. So again, we want to hear your perspectives on the situation we're in and your ideas about how we will recover from this crisis. So with respect to the Getting Southern Maryland Back to Work initiative, this is a collaborative initiative of the Tri-County Council and the College of Southern Maryland to prepare our workforce for economic recovery, a new workplace normal in response to the COVID-19 pandemic. Workforce development arms of both of these two partners are aligning federal, state, and local investments to provide industry-recognized trainings and certifications. These investments are enabling our regional partners, including you, to provide targeted responses to your critical needs, and thus equipping Southern Maryland to respond agilely to the challenge before us, redefining and reshaping our workforce. As you know, the pandemic has caused unprecedented unemployment in the United States, and Southern Maryland is not immune to this impact. The Maryland Department of Labor reports that unemployment in Southern Maryland has climbed to 8.4% as of May, up from 3.3% in March, with the greatest impact seen in retail, construction, and in healthcare. This initiative aims to create clear pathways for residents who are unemployed, underemployed, or in need of a career change as a result of the crisis. The initiative has three key objectives: investing in emerging skill needs, responding to business needs, and reshaping workforce development for the future. And I want to say a little bit about each of those. With respect to investing in emerging skill needs, the partners recognize that the pandemic is changing the knowledge and skill requirements of workers across industries. Safety, sanitization, and remediation are now common workplace practices, and employees at all levels require training in those areas. CSM has already enhanced industry training to include COVID-19 awareness and safe worker, safe workplace protocols. The partners are also preparing for emerging occupations that require new skills and certifications. They're developing new certificate programs for infectious control and barrier protection, contact tracing proficiency, community health liaisons, and more. Secondly, to respond to business needs, the partners are first and foremost listening to businesses. To determine priorities and develop successful programs, they're forging alliances with the Workforce Development Board, which has representatives from retail, hospitality, construction, information technology, and yes, healthcare. And with the region's partnerships also with the region's chambers of commerce, county economic development departments, and industry associations. The partners are holding town halls like this one. By listening to business, they've already created and are implementing high impact trainings, not only for job seekers and career changers, but for organizations seeking to upskill current employees. Finally, it's clear that we must collectively reshape workforce development for the future. The pandemic challenges us to reimagine Southern Maryland workforce development as adaptive, agile, nimble, able to respond to emerging needs quickly. The Getting Southern Maryland Back to Work initiative is coordinating the efforts of stakeholders to provide critical training, capturing best practices, but also innovating, reshaping curriculum in both content and delivery. In short, Getting Southern Maryland Back to Work is engaging the entire community in designing a responsive, high-impact workforce development system that will rebound our economy. And so the Tri-County Council and CSM are today engaging you in conversation to examine your specific workforce recovery needs. To begin our discussion, we're fortunate to have with us two local leaders among leaders. Elaine Hardy, Human Resources Director at Charlotte Hall Veterans Home, and Dean Teague, President and CEO of Calvert Health. So a little bit about each of them before we begin our conversation. Elaine Hardy has served as Director of Human Resources at Charlotte Hall Veterans Home since 2017. Before that, she was Director of Operations for Adult Medical Day Treatment for the Washington Center for Aging Services. Close to my own heart is that Elaine has been an instructor of social sciences at the College of Southern Maryland since 2006, and so playing an instrumental role in developing our young people for our local workforce. Elaine has been a human resources specialist for 15 years and specializes in the strategic development of innovative HR initiatives to streamline processes and capitalize on organizational growth opportunities. So she is the right person to have with us today for the conversation we're about to have. So thank you, Elaine, for being with us. Dean Teague has served as CEO of Calvert Health since 2015. He joined Calvert Health in 2012 as Chief Operating Officer. Before coming to Calvert, he spent 6 years as Vice President of Operations at Washington Adventist Hospital in Tacoma Park. Dean has devoted most of his career, however, to the United States Navy, from which he retired in 2006 after 24 years of active duty. During that time, he served for 3 years as the Senior Administrator of the White House Medical Unit, which provides health care for the President, Vice President, and Cabinet. Dean is a board member, Region 3 Policy Board of the American Hospital Association, and a fellow of the American College of Healthcare Executives. So again, we're just really thrilled to have Dean Teague with us this morning. So thank you both, Elaine and Dean, for being here. So I want to just check in, and are you both ready to start our conversation?
Yes, this is Dean, I am. Yep.
All right, good morning, Dean Teague and Elaine Hardy. Are you here? And
this is Elaine Hardy. How are you? Good morning, everyone.
Good morning. Good morning. It's so nice to have you here.
Good. Good.
So I have a number of questions just to sort of get our open conversation started. And the first is something that I mentioned in the overview that actually surprised me, and that is that Southern Maryland's healthcare industry is among those with the highest unemployment, along with retail and construction. I knew that all industries were affected to some degree by loss of jobs, but I really would have expected healthcare to be among the least hard hit by unemployment, given that this is, in fact, a health crisis. So could you shed light on what is actually happening? Where are we finding pockets of unemployment? Where are the challenges there?
Yes, ma'am. So today, what I wanted to share was Charlotte Hall Veterans Home, our particular, and I would say all healthcare industries, I'm sure Dean could attribute to this as well. We've taken a major hit due to our employees having to take time off as a result of all of the other underlying health concerns, family members that they supported. They still have the same concerns as others who are not in the healthcare industry. But what makes it more difficult for us is that when they also, because most of them are frontliners, and so they are being directly affected. I know 20% of our workforce team was directly affected by a positive result of COVID-19. And so when you have that happen, for us, that was about 91 employees. And so that put a humongous strain on us. And then you're dealing with, if it was continuous underlying issues that caused them to remain out of work, as well as the whole mental health fear of returning back to the workplace and the fear of, being reinfected. So that's the stress that we dealt with primarily. Of course, a large component of our employees who were out were certainly the direct service staff. So that required us to reach out and do some kind of some other unconventional kind of hiring through travel agencies. I've hired people from all over, travel nurses and GNAs from all over this country who have been within our facility. So that is some of the challenges that we face. And during that time, obviously, the employees are entitled to reaching out and utilizing unemployment services during that time.
Thank you. Dean, what are you seeing?
Well, I'm kind of at a loss. We did just the opposite. We actually, even employees that were in areas that were not considered direct healthcare, we redeployed them. We haven't laid anybody off at all. We've had 4 employees I know of that have left on their own because of concerns with COVID. But in order to keep the workforce engaged, especially let's just use dietary and housekeeping staff, they would have made more money had they gone out on unemployment than they actually get paid at the hospital. So we put in hazardous duty pay for a lot of our employees just to keep them on the payroll and engaged. We took staff that were in areas like cardiac rehab, people that are in the admitting office. We weren't admitting as many people as we were before, or people that worked in same-day surgery. Redeployed them as nurses up on the floors. And so instead of our normal nursing ratio being 1 nurse to every 5 patients, if it was a COVID floor, which at one point we had approximately 30 patients was the most we ever had at one time, it would be 1 nurse to 2 patients. So we took that opportunity. Now, it did cost us money, but it was worth it in the end because we did the right thing for the community. Also, we made a decision in the month of April. There were 2 pay periods, the first 2 pay periods when COVID got a little bit crazy, where instead of taking employees and putting them out on paid leave, PTO, we absorbed the cost of the PTO so that there were some employees, for example, in our billing department that we didn't need, that were working that were at home. We paid them during that time period out of the hospital payroll so that in the month of May, when it got even a little more hairier, those employees were still able to use the PTO they didn't use in April, so we were able to cover them. It cost us a few $100,000, but it was the right thing to do for the employees. We have redeployed a lot of our nurses that were on general nursing floors into the ICUs and trained them up. So we're now in a position where we went from running a 6-bed ICU to an 8-bed ICU every day. And at one point, our PACU, which is our post-anesthesia care unit, became another ICU as well. And we had 5 patients in there because we weren't doing same-day surgery, only emergency surgery. So Now, where we did see some unemployment pop up, and this is even true with us, was in our employed physician group, which is the groups that are outside of the hospital themselves. And there were a number of private physician groups that had employees that were working for them, but they had no patients. They didn't have the payroll, the ability to cover them. So then they would furlough their employees, who then went out onto unemployment. A lot of them have already brought them back. We're extremely busy here in the hospital. We're busting at the seams because we're trying to catch up for the last 3 months of all the elective surgeries we didn't do. And so after we closed or we started changing back to regular business operations, those employees that were redeployed were deployed back to their workspaces. And so we're moving forward with that. I will tell you, we still are at a shortage with nurses, as we always are. And I think it was Elaine said she brought in contract nurses. We brought some in ourselves as well, because they're just not available in the community. And then there was a change that happened where CSM graduated the nurses. They hadn't really completed their courses. They hadn't taken their license test yet because they're not available. And so then the requirement came from the Board of Nursing that said that you cannot hire those nurses as a nurse, well, 1-to-1, meaning one nurse that has a license working hand in hand with them on a daily basis. So we've not been able to hire some of those nurses that we would normally hire. We have hired 5 new grads, but most of them are from 4-year programs outside of the area.
Wow, so there's a lot there of real interest and value. So what's really fascinating is the way in which you very quickly and nimbly redeployed employees. That's extremely impressive. Do you find that other systems were able to be as successful? I mean, as you communicate with other hospital administrators, did you sort of seize on a secret sauce or an opportunity here that others were not able to?
I see where you're going with that question. That's a very good question. I will tell you that we're an independent community hospital, so we're one of one, as you know, and we make decisions in the room I'm sitting in right now with my executives. And when this got crazy, every morning at 8 o'clock, we were in this room every day, Monday through Friday. Saturday to Sunday, and we're meeting with the county and with the health department to figure out what the next steps were. As far as other health systems go, there are larger systems that are up in other counties that have furloughed thousands of employees. And so they didn't have, so if you take a look at a large system like, I'm not going to throw any names out there, just say a large system that has a large employed physician group, they're going to be doing a lot more furloughs than you would see from somebody like us. Now, I only employ at this particular point about 20 physicians and mid-level practitioners. But Calvert Internal Medicine, we work very closely with them to make sure that they had their positions covered. And quite frankly, and I'm not going to we were extremely blessed that Southern Maryland didn't get hit as hard with the COVID as it did up in Montgomery and Prince George's County and Baltimore County and Anne Arundel. And in fact, we were taking patients from Anne Arundel down to Calvert to help them out. And we redeployed some of our equipment like ventilators and things up into Anne Arundel, Doctors Community Hospital, and other places that needed that equipment. So just because we are independent and we do have the ability to make decisions here, it's very different than I think than some of the larger systems.
Yeah. But kudos, that again is extremely impressive that you were able to sort of keep people going, and which of course is just a benefit to everyone who needed that support, who needed that health care. And so in thinking about the folks who unfortunately have been furloughed, or as Elaine was mentioning, who found that they either had to attend to their own health or the health of family members, and who did have to leave. I'm wondering about these folks who are going to want to return to employment soon. So do you, and this is for both of you, do you see, or what opportunities do you see for them to return, let's say in the next 6 months? So what I'm after is sort of a sense of just what the next 6 months is going to look like in terms of positioning people either into their former positions or new positions.
Well, Sybil, I will just chime in and say that just like Dean, and I apologize, I didn't mention, we did also redeploy our nursing administrative team to various other areas of direct services. However, of course, there's no way for us to obviously predict the way that the pandemic is going to continue to move in the next 6 months, but we certainly have had to look at how this has impacted our business structure as well. Not being able to readmit, and of course, for those who are listening that may not actually know, we are long-term care, which is a little very different than the acute care services that Dean and his team provides over there. So our employees currently, the ones that are out, and I mentioned that 20% of our staff have been, directly affected by this. However, that did not mean that they have not returned to work. So we did recover out of the 91 employees. We did recover all but 2 of those employees right now, in terms of those who were out due to positive COVID. However, with the issues that we've had to close down some units because of us not being able to readmit yet. And so as a result, that is impacting us. And now looking at the staff, my administrator who avidly says that he does not want to lay off. We do not want to furlough anyone at this point in time. So we are doing the very best that we can to see how we can redirect all services here. We've even taken some GNAs and used them in other areas that since we've closed down 2 of our units right now, we've had to, utilize those GNAs in other areas of work here. So we're doing that as well. I can't say how the next 6 months really look for us, but we're striving as much as we can to keep everybody on board.
Yeah, Elaine, I would agree with you. I would like to point something that's kind of critically important here is that we have a very, very close relationship with Charlotte Hall. We receive a lot of their patients when they do need primary care, hospital care, which could be regular hospital care or ICU care. And so the issue that we had was that, when we got somebody here who was tested positive for COVID and came from a nursing home, we kept them here a lot longer than we probably normally would have because we wanted to make sure they were clear because we didn't want to send them back and have other issues. And so that was one of the things that we actually had to keep more staff on for. The question that you bring up about getting people back to work, we have brought everybody back at this particular point. My ORs are going crazy. We've got a lot of surgery going on. One of the things that we're seeing here, and we're having a tremendous problem with, our volume in our ED is not as busy as it normally is. We normally see between, let's just take last October, we saw on average 135 patients to 140 patients a day. Right now we're seeing between 80 and 100. And the problem is that the people that are coming in are extremely sick. They're staying home. They're afraid. They think that, they're going to come to the hospital and get COVID and they're going to die. And they're sitting home with congestive heart failure. They're sitting home with, we had one gentleman 2 weeks ago who had a stroke and waited 2 days before he came in to get treated. And now his long-term, outlook is very bleak. He's got a lot of work he's going to have to do for rehab. And so when we get patients like that in and we're extremely busy upstairs, we wind up keeping them in the ED, which means we wind up bringing more people into work. And unfortunately, I shouldn't say unfortunately, we have an excellent behavioral health service here in the hospital itself, and it has become extremely busy. And it's a dual diagnosis, substance abuse / behavioral health. And so we brought more staff in for that because we want to make sure that we keep those ratios. Because one of the things you have to consider, and I know that Elaine does the same thing, when you bring a nurse in, you work them 12 hours and they're seeing, let's say 2 COVID patients. Every time they go in and out of that room, they have to put PPE on and take it off, on and off, on and off, on and off. And at the end of a 12-hour shift, they're pretty burned out. And so you need to make sure that you've got the ability to give them the time that they need to kind of recharge their batteries. I knock on wood, I'm extremely proud to say we haven't had an employee acquire COVID from a patient. We haven't had any direct COVID COVID-related diagnosis to employees from patients. Now we have had employees that have had COVID, and it's usually community acquired, and they're out for the 14-day time period. And there were some special exemptions for healthcare workers as far as how long they had to be out. If they came back and they were free of any symptoms, then we could do 2 negative tests. We could bring them back. And so, we've done the exact same thing. I think the approach with Charlotte Hall and with us has been similar to what other healthcare organizations have done, is redeploy, keep the employees on that you can, and then try, and the ones that are working from home, get them back as soon as possible. I will tell you though, the whole healthcare system has changed. Telemedicine is the way of the future for primary care, and it's also becoming that way for specialty consults. We did a lot of neurology telehealth with our neurologist, who would call in from home, would do the consult with the hospitalist doctors, and that's going to be the future of where medicine is going. So it's going to be interesting to see what the next 6 months to even 3 years hold when it comes to this whole way of doing business.
And so, speaking of this whole new way of doing business, I have really sort of 2 related questions, and this will be my last question, and I'll open it up and allow other people to weigh in. And that is, so you've mentioned both of you have mentioned behavioral health, mental health. And the question I have is, what are the needs going forward to really equip healthcare workers to sort of, come back strong, come back and thrive. So that's one side of it is, in terms of mental health, and then other kinds of training that would enable them to come back strong. And then the other is has to do with recruitment. So you both have mentioned the challenge of keeping nurses and recruiting nurses. Are there other recruitment challenges you face in the next 6 months to a year, let's say, that you would say are sort of current priorities?
Elaine,
Charlotte Hall, we've made mental health services available for our employees, because again, we have taken a great hit with with COVID-19 within our facility. We work very closely with our medical services and our mental health services programs that we have in place, and they come, they make appointments and meet with our employees off-site. Obviously, they do have 24-hour access to be able to call and discuss anything that's going on, any fears, any inhibitions into returning or working here at Charlotte Hall. So that's been very helpful for us. And the other piece of it is, I just drew a blank on the last part of your question, because I actually wanted to address that. Can you? Recruitment. Right, the recruitment. So with regard to recruitment, we too have had a co-op with College of Southern Maryland, and at the beginning of this, we had students who were registered in the GNA program with that co-op with Lori Proctor. However, because of this, the class was interrupted, and so a lot of things kind of got off track with that. I do intend that that's a program that we will continue with the College of Southern Maryland. It was definitely something that was great that Lori and I put together, and it has fared us well in the past. In terms of really the real fear that I have as a human resources professional is it appears that a lot of our employees are really thinking about realigning their career goals, and so that's the fear. We already were looking at a shortage in the healthcare industry by the year 2024, and I think this pandemic is going to highly impact that even greater. So that's kind of where I am with that right now.
Mm-hmm. Thank you. Dean?
We have similar programs. Obviously, my human resources vice president, she's actually, she took a week off and went to Ocean City to her house. I don't know why she would do that, but actually, it's right. Yeah, it's right. It is Ocean City. But she has, we have an EAP program, an employee assistance program, again, for anybody who is struggling. And it could be behavioral health. It could be, family issues. It could be just about anything. I tell the employees in orientation, when you come to work in a hospital, you'll see every single human emotion come through that door today. Somebody's going to die, somebody's going to be born, somebody's going to get a diagnosis they want, somebody's going to get one they were praying that they didn't get, but they got it. And so we have to work on the employees all the time, not just during these pandemics. And what we try and do is we try and make sure that people understand that Calvert Health is about taking care of not only the community, but our employees come first. And so we spend a lot of time as an executive team going out and checking, like, what's going on, how you doing, what do we have today, to ensure that the workforce is not in a position where they're having a tough time and they're struggling at home. During this whole thing, I had one of my employees kind of break down when I was talking to her. It turns out her husband was diagnosed with a cancer. And she didn't know where to turn, because during the pandemic, there's really, what's the next steps? Who do you go see? Everybody's trying to, do this COVID thing. We were able to get him in. He's actually been at Johns Hopkins now for 3 weeks. He's doing very, very well. But, she probably wouldn't have stopped. She probably, walking down the hallway, she probably wouldn't have said anything to me, but I noticed something was off with her because I see him all the time. So, that's one of the things we do is we focus on the staff. It's easier to keep people here employed when they want to come into work because you make it a place where they want to be. And so, having worked in the Navy, I told you, one of my goals when I was in Iraq, I pulled all my folks together and I said, here's the deal. Nobody goes home. Nobody needs to go home other than on the plane or back by the ship. We worked very closely together, and it was all about teamwork, taking care of everybody. And we do the same thing here. We try and make sure that we work as a team. And when you see nurses and techs that are pulling together with these patients that were critically ill, you can see their emotions at the end of the day when they lose somebody or somebody passes, and you just have to make sure that you put the programs aside for them. As far as recruiting goes, everybody's struggling with recruiting nurses. We've talked to the College of Southern Maryland numerous times. As you know, Charles St. Mary's and Calvert are part of the Potomac Alliance, and we provide information input and sometimes funding to the nursing program. And we need to continue to do that. We need a 4-year program. The difference between a 2-year nurse with a RN degree and a BSN nurse is that it's about 6 months when it comes to orientation. A BSN nurse takes about 6 months less orientation than a nurse coming out with a 2-year degree. Not saying that the nurses coming out with 2-year degrees aren't outstanding nurses, they are. They just didn't have the time on the floors like a 4-year nursing degree has. So we will continue to struggle with that. We'll continue to work with the College of Southern Maryland and the University of Maryland to get those 4-year nurses and the 2-year nurses that we have to get them up to speed and running. And then what we try and do, even when we have a nurse that comes in and has an RN degree, we try and get them into a BSN program through one of the usually online programs, Walden and a number of others, to get their BSN. As far as the recruiting of others goes, you always have openings in housekeeping and dietary. You continue to constantly bring folks in, but our goal at Calvert Health is to take those employees and actually work with them through tuition assistance to get them into a different job category at some point inside of the organization. Some people are all for it. Some people just like what they're doing, and that's what they do, and they're very good at their jobs, and we're very happy to have them. So those are some of the things we have going forward. Challenge is always with us is hiring physicians. So if you know of any doctors looking for jobs, we're actually hiring all physicians.
All right. Well, that I am really sort of intrigued by, and I'm aware that there is a primary care shortage, and so I imagine that sort of plays into the shortage you're encountering. But keep that in mind. Thank you both so much for giving us sort of this running start to this conversation. I especially want to thank you for the care that you are clearly giving to those who are on the front lines really working hard, because that also, it's intrinsically valuable, but it also really spills over to how we are in the community cared for. So I just want to say thank you for that, for the commitment.
Sybil, yes. Hi, we have some questions in the chat. The first question was some time ago. They wanted to know if a copy will be made available so they can share it with the directors.
A copy of this presentation.
Exactly.
So it is being recorded, and I defer to Ellen Flowers Fields and Ruthie Davis about what will happen to this recording.
Okay.
Uh,
Our
so-
next question.
So I was going to see Ellen or Ruthie. Do you want to? Can you weigh in on that?
I'm not really sure whether the recording can be shared. We have an expert on our team, Karen Adams.
It can be. It can be.
Can't?
It can. Yes, it
Can.
can. Yes.
Okay. So we will plan to share it.
Thank you.
Okay. Our next question, thank you, Ruthie. Our next question is, with the expansion of telemedicine, what capabilities, new staff, or skills are needed to support this service delivery?
Elaine, how much are you doing as far as telemedicine goes?
Not much. As far as our residents, of course, they're utilizing that even more now. But in terms of our employees, several of our employees we do make that available through our benefit services. So they have utilized that. It actually is way more obviously than ever, of course, during the pandemic. So that's. But as far as our residents, yes, we use telemed all the time with them now. That's the only way.
So as far as the establishment, setup, and operation of telemedicine for us, it's typically it's primarily in the primary care area. How's that? So I keep looking back. Teresa Johnson's here with me. I'm sorry, she's my vice president of Foundation and Public Relations. So it's a completely new field. It's been around for a while, and a lot of insurers were using it. So Care First was using it. They were probably one of the first ones in the area, United and others, because they found it as a way to provide primary care at a much cheaper rate, and the savings was they were able to use in other areas. The pandemic allowed for us to establish immediately the telemedicine and primary care, because the reimbursement went from, like, I don't know the exact numbers, so I'm going to just say it went from $20 to $60 a visit. And if that's the difference in what it takes to make sure you're breaking even, that's okay. What we're starting to see now is like Medicare and Medicaid have gone back to the $20, and so we're going to have to figure out how to do it cheaper, and we're going to have to figure out how to do it more efficiently. It's something new for our providers, and some of them like it, and those would be the millennial providers, the provider that's under the age of, let's say, 40, the provider that's over the age of 60, still carries a black bag and wears a stethoscope around their neck and would rather go to a house than see somebody via a computer. So it's taken a little bit to get used to. I will tell you this, though, our patients, especially our elderly patients, like it an awful lot because they don't have to go into an office. They don't have to be exposed. They can get the things they need. But then as a healthcare industry, we have concerns. I mean, when somebody says they have an ear infection, the doctor's looking at them. They have really no way right now of putting a camera in the ear and actually seeing it. So they're writing a prescription for an antibiotic based on what they're seeing from the patient, based on the information they're getting. And so now we have concerns about our antibiotic stewardship. We're trying to reduce the amount of antibiotics being used that are being used inappropriately. And so there's this twist that happens inside of these things. It's a good thing. I can get seen by a doctor right now. He's going to write me a prescription. I go to Walgreens. I'm good to go. And then there's the, so I have this other issue that I need to be taken care of. Is it a telemedicine thing? Well, you get on the phone with the doctor and they're like, no, you have to come into the office. It inconveniences the patient at that point. It puts another touch point in there. So it is really, it's really something neat. It's not going to go away. I guarantee it's 100% is not going away. How do we make it better? How do we make it cheaper? And how do we make it more easy for the patient? And that's what we're kind of working through now.
All right, thank you. Before we go to questions, some more questions, I understand that there is a poll that the initiative would like to have participants complete. And so in the chat, you should see now a link to the healthcare industry poll. If you would just take a few moments to answer the questions there, we will resume our open discussion in just a moment. And if you have other questions or thoughts, once you've completed the poll, feel free to go ahead and put those in the chat as well. Okay, does everybody see the link now? Okay, yeah, good.
Am I supposed to fill it out?
Yes.
You want me to do it now? You want me to fill it out?
Yeah, we can fill it out as well, yes.
Oh, good Lord.
Please do.
Now I got to put my glasses
Elaine.
on.
Elaine, you too.
I just did the chats. Healthcare industry poll. Is this who was the poll by? Do we know?
Okay, so Karen Adams posted it. You might see a healthcare industry poll, but beneath that hyperlink, HTTPS, etc.
And the questions were developed by the partnership of the initiative.
Thanks, Ruthie.
And we invite all industry members to take the poll.
Okay. So to our moderators, feel free to resume with questions at any time.
Okay, we have one question here. Burnout for frontline workers is a very real issue following major crisis periods. Are there positions that you feel are particularly vulnerable within your organization?
Let me take a stab at that, because it's it actually can be almost not necessarily. I mean, I could easily say, yeah, ICU, ED, frontline nurses working with COVID patients. It comes down to the individual and their understanding and their belief structure. We have physicians that will wear PPE from head to toe. If they could put themselves in a bubble with a negative pressure balloon around them, they would. And so it was critically important for us to provide the equipment to them. And I just say every day, thank God I have the team that I have, because we were able to get all the PPE. We had most of it all anyways. And what we didn't have, we got creative. And I will tell you, the community of Southern Maryland was amazing with the outpouring of the donation of PPE, of the engineers in the area. They're in the aerospace and government contracting areas were building face masks for us. They were building gowns for us. We probably have at least 10,000 cloth masks that were made by members in the community that were donated to the hospital that we give to our patients. And so when you work in a community like this, you realize how lucky you are to have such a talented workforce that even when they're not working in their particular industry, they're thinking about what they can do to help next. And so when you talk about burnout in the organization, that's one of the things you have to keep in mind, and that's what you have to train your leaders to look for. And some of the simple signs of burnout, you just don't really even think it's a sign of a burnout, but it's a nurse who's struggling to get a computer entry into get a pharmacy order for a patient that's in the unit. Why is she struggling? She wasn't struggling yesterday. Let's check on that person to make sure they're doing okay. it's given them the time that they need, if we can at all possible. I will tell you, during the pandemic, we canceled all vacation. There was no PTO. And unless you were considered non-essential employees. And even then, we didn't want you going out of the area because of all the requirements from the FDA and the HHS and CMS, CDC about, quarantining and everything. So, burnout is something you take seriously in healthcare 24/7, 365 days a year, because you do see some horrific things. You do see some people that you don't understand why aren't we able to save that person? When you like a classic, we usually have one set of twins a year at this hospital. We had two sets within 6 days of each other here at Calvert Health, and one of the sets of twins, they were born early. They were born at 37 weeks, 36, 37 weeks. Normally we would send them to Children's. Children's had no way of taking them because they were so busy. So we had to become creative and work with Children's via telemedicine, so that we had these kids being monitored, and we were able to, quote unquote, fatten them up to get them up to speed so they could be discharged. And so, when you're working with your nurses inside of labor and delivery, they're not used to that. And all of a sudden now you throw something new at them, and they're scared, but they know what they have to do. And so you have to be observant of them with burnout. So I'll leave it at that.
Thanks, Dean. And we have about 4 or 5 more minutes. I'm sort of curious to hear what is happening in other corners of the industry. And so those of you who are on the line, if anyone wants to talk a little bit about what's going on in your area, please feel free to unmute your mic and weigh in, please.
Hi, I'm April Kraut, and I'm an HR manager for a nonprofit within DDA, Developmental Disabilities Administration. And one of our hurdles that we had was we had to shut down our day program when the phases started. So we kind of went into lockdown mode and had required our staff that worked additional jobs. We asked them to either pick up more hours with us, or, leave their second job and pick up more hours with us. Or if they didn't want to do that, then, they would be put on leave of absence because we couldn't afford to risk, our clients, getting any, getting sick. So that is really, knock on wood, has worked for us. We have not had any positive COVID cases within our clients, or staff. So we've been really, really lucky there. And now with trying to, we're waiting on phase 3 from the governor because we can't start up our day program again until phase 3. So hiring new staff is going to be kind of a challenge, because we're going to have to keep the restriction of, we ask that you don't work a second job for us, because it's just too scary to risk the cross-contamination, because a lot of them work, additional healthcare jobs that could put them at risk, and then them not knowing they have it and then bring it in and such. So, but we've been really lucky as far as PPE. We've been able to have adequate PPE for our staff. They're required to wear their masks and gloves and everything in the house to make sure that, they're protective against the, protecting the clients against anything. So
thank you so much for sharing that. That's being on the outside of the industry, it hadn't even occurred to me that you might confront sort of a situation in which people are looking for other positions in healthcare settings, and that pose, the way in which that can pose another layer of challenge. So thank you for sharing the situation you're in. As Ruthie will share in a few moments, there will be some follow-up from the partners in this initiative to continue to be in dialogue with you and others on the line. So thank you again.
Sybil, I think Elizabeth had something to add.
Yes,
Okay.
I sure did. Hey, hi. Just like the former speaker, I work for a large nonprofit. I think the paving the way to success that we've had so far was to choose, our agency chose to put our folks that couldn't work directly with our participants with disabilities on paid leave of absence. That was a choice that our board made. This was terrific because when we needed to bring everybody last week back in to train and retrain, we were able to do that without any loss of staff. What I had to do in order to prepare myself to deliver differently as we're, moving into uncharted waters, I had to completely reshape the curriculum, content, and delivery. So we do a lot of our delivery to our folks that would normally come to us during the day. We're doing that virtually now. And that was a huge learning curve for both our staff and our participants. So that's what I wanted to add. I think it's been scary. We have extensive protocols in place, but you can't prepare for the unexpected, but we're doing our best.
Thank you, Elizabeth, for weighing in.
Yes, I agree with what she was saying. The Zoom calls and everything that we're able to have with our clients and our residential homes and our personal supports, that has really, really helped. The clients are really engaging, and they've really, really enjoyed that. We've been able to have guest speakers, everything from space sciences to art to everything. And they've really, really enjoyed that. And it's a safe environment for them.
That's great to
Okay,
hear.
John had something, Sybil.
Yeah, my question is, one of the things that we're seeing is struggle with complacency in our workforce. People are so tired of being at home. They're so tired of working shifts and their life becoming go home, go to work, go home, go to work. Has anybody else encountered that? And what are other organizations or other places doing to try to combat that? We don't want to be the type of employer that says you can't take leave, you can't go somewhere. But at the same time, we have people going to hot spots like Florida and then trying to come back into our workforce. And, we're trying to grapple with finding that balance. Dean spoke heavily about that mental health component. We don't want our employees to burn out, but at the same time, we want to keep everybody, I'm with the ARC, and we've had a very low COVID positive testing in our staff and our clients, and we want to keep it that way. But our employees they're becoming restless. They're tired of the monotony of the same routine. So has anybody else found a creative or how are other places handling that struggle?
Can I just take a crack at that real quick, John? First off, I want to thank you because we miss our ARC employees, our volunteers here. We have 800 volunteers on our rolls. 600. And we have a number of them from the ARC that come in, and we have they just do wonderful work for us, and we haven't been able to bring them in at all. And so we miss that piece of that interaction of the folks that are, that are coming in and doing things for us that are just, things that we take for granted when they come here, and it would be a whole different position when they get here. I will tell you, I made a huge mistake. I came to work 88, 89 days straight without taking a day off, and I suffered for it. I wound up with bilateral pulmonary embolisms a couple of weeks ago. I think it's because I was sitting around too much. I thought I was walking. We don't know why. We're still trying to figure it out. But and that piece of coming to work, spending 10, 12, 14 hours here, and then going home, that cycle, as you say, is monotonous. It's been a strain. My wife and I have been married 35 years. She asked me recently if I could go on one of those Navy trips where you go away for 6 or 7 months. And so you're right about having to find creative ways of doing things. I think what we're seeing a lot is we're promoting a lot of people getting out and walking around the campus. People, when you go home, get your kids and go to the playground. Be outside. This is the time of year to be outside. The virus does not transmit easily, especially when it's so dang hot and humid like it has been lately. And work through that. I would love to say there's a magic switch where you could say, do this, this, and this. It really is a hard thing. And this is something the country was never prepared for in any way, shape, or form. And then you throw everything else that's going on inside of the country and the world, and you think to yourself, where's the next turn? I read something the other day. It said 2020 is the year of the rat. That's in Chinese calendar, and it started with a plague. What's going to happen for the rest of the year? So we prepare for every single day for what we're doing, and I think that how you handle it yourself outside of work is very different. I looked down the end of the couch and there was a lady sitting there watching TV with me, and I realized it was my wife, and then she was very nice, but I normally watch sports and there's no sports to watch, so now we talk. So yeah, it is a challenge. I completely agree, and I don't have a magic bean for that. I wish I did.
Thanks, Dean. So we have time for just one more question, and then we will hand this over to Ruthie Davis to close us out.
Great. Donna was waiting patiently.
Great.
Donna?
Apparently, I must have turned her off.
Donna, did you push mute?
Can you hear me?
Yes, there you are.
Okay. So I'm Donna Retzlaff from Springdale Center, and we do a lot of work with John and some of the other nonprofits that are on the call. And I think I just wanted to just reiterate that even though we're nonprofits, we do a lot of direct support work for people with developmental disabilities within Charles, St. Mary's, and Calvert counties. All of us collectively support a lot of people, and I think it's safe for me to say we were experiencing a workforce shortage prior to COVID. And so just like the hospitals, we are in the midst of yet still a serious workforce shortage. And, it would be really interesting to see how we could move forward to continue to develop the workforce of direct support professionals, just like we may be looking at for your hospitals and your nurses and your doctors. It is truly a workforce that oftentimes goes unnoticed. It's a much lower paid workforce, and unfortunately, they do have to work 2, 3, 4 jobs just to make ends meet and to be able to afford housing. So we've also looked at, trying not to do the cross-contamination, but it is really, really a challenge because people do need those multiple jobs. And that might be something for us to look at moving into the future as well, is how do you handle a workforce that does have to work multiple places? So that's all.
Thank you for that, Donna.
I just want to piggyback on what Donna said. We're in the same boat with the ARC. We're actually reaching out. Virtual job fairs. We're reaching out to Pax River. We're actually in a crisis. A staffing crisis is probably the only real way to describe it, because we're reaching a point where we're not going to be able to expand. We're not going to be able to continue to admit people to the programs if we're not able to find a way to staff them. And that's, a real critical problem in Maryland is finding staff. There's no shortage of people who need support. But there's a huge shortage and it's not just finding people, it's finding the right person. Because we have, and I'm sure Donna and April, I work with both of them, I'm sure they'll support me in saying this, we've been the rounds with hiring, and not everybody can do the work that we do.
That's right.
Yeah, agreed.
Thank you, John. Ruthie?
Okay, I want to be respectful of your time, so I'll make this short, but I wanted to thank everyone that's joined us today, particularly those who are industry members. And on behalf of the Tri-County Council for Southern Maryland and the College of Southern Maryland, I really thank you for joining in on this critical initiative. I also want to thank Sybil for her stewardship of this morning's meeting. Thank you very much. And my partners in crime in this initiative, Ellen Flowers Fields, who is the Associate Vice President of Continuing Education and Workforce Development at the College of Southern Maryland, and Pam Wilkerson, one of my colleagues who's the Workforce Operations Manager. Now, in terms of some follow-up, and Dean and Elaine, thank you both. That really helped get our conversation started and going, and we appreciate your support. Going forward, if you answered yes to any of the poll questions, we will be in touch with you to follow up. If you didn't answer yes to any of the poll questions, please expect an email with more information on how to connect and more information on when we might try to do this again, which is going to be necessary going forward for years. Thank you all very much. And by the way, I'll put out information on where you can find the link to the recording.
Thank you, everybody.
Thank you.
Thank you, everyone. Great conversation.